welcome you guys to the presentation today on harm reduction. First, I want to start out and go through some continuing ed information, just so you guys know how to go about getting your certificates and completing the evaluation. This event has been approved for 2 contact hours through the Alabama Board of Social Work, the NVCC, and for 2.4 contact hours through the Alabama Board of Nursing. So to go about getting your continuing ed certificate, what you'll have to do is complete the evaluation. So an evaluation will pop up at the end of the Zoom. So on the post attendee page that you often see when you've clicked on a Zoom link, and then it pops up on either your Google Chrome or Safari or whatever, the evaluation will pop up on that page. And then I will also drop the evaluation link in the chat as well, so you'll have access to it there. When you complete the CE request form, you'll indicate if you need credits for the social work board, the Board of Nursing, or for the NVCC. So that's so we can separate out your credits, make sure everybody's getting the correct ones. You will have your certificate within 7 business days. So 7 business days from today is actually October 18th. You will probably have it before, but if you don't have it by then please contact me. And you're able to contact me at apcbham.org. All right. So when you complete the evaluation through SurveyMonkey, if you need CEs, you're going to click on this link here. It'll be formatted with the correct day and the name of the event as well. So you'll click on that, and then it'll take you through the process to request your CEs. All right, and then I just want to point out 2 of our upcoming trainings that we have next week and the week after. Next week's training is on substance use disorders in the family, and then on October 21st, the presentation will be on substance use in adolescents, prevention and treatment. That one will be done by Dr. Rebecca Savage from UAB Medicine. All right, and then just a shout out. Oops, my bad. And I realized when I changed the background on this, we're missing one of our partners on here. But shout out to Not One More Alabama, CAPI at UAB, and of course the Addiction Prevention Coalition and the Drug Education Council in Mobile. All right, so Jack, you have the floor.
Awesome. Thank you, Ashley, and hello, everyone. I'm going to just share my screen real quick, and we are going to dive into this. So today's topic, harm reduction. It's a pretty controversial one. You know, as I was thinking about it, there's a lot of history that comes with harm reduction in multiple contexts. We're also kind of looking at, the historical and kind of anthropological impacts of substance use disorders across our society. And it really pings a lot of what do we think about and how do we show up to substance use disorders in our society? So I'm excited about this topic. And before I get started, we're going to have fun. And I kind of just wanted to go over, who doesn't love this GIF, right? It's the most adorable. It was either this one or the Forrest Gump one with Forrest waving. But I went with this one. And just a couple of things. I do want to say thank you to the Addiction Prevention Coalition, NOMA and UAB for having me and offering the opportunity to talk about substance use disorders and specifically harm reduction. Harm reduction is not an easy topic to talk about. I also will have the chat open, and also please ask questions in the Q&A, which I am also pulling up. I am here to, kind of facilitate and go through any of the questions that you have as well. So glad to see that the chat is happening, and I am happy to kind of be monitoring that as I go through. And at the end, I'm going to certainly leave some time for questions, probably about 10-15 minutes for discussion or anything. but I really will also try and elevate people's voices. So if you're asking questions or putting stuff in the chat, I might kind of pause and name that and bring it out so that all of us can kind of hear or see that content. And another thing that I just kind of want to focus on briefly is just being mindful of what's coming up for you as you maybe hear some of these ideas or strategies. Being mindful harm reduction is but a part of how we approach substance use disorders, and some of it you might not agree with, just fundamentally, moralistically, idealistically, or you might say, I haven't seen any evidence or research on that. And so I don't feel comfortable promoting that. And that is okay, right? This topic is really for you. You know, I'm hoping to kind of just plant some seeds and ideas of how you might be able to use harm reduction strategies, both on an individual level, whether you're in a peer support role, whether you're a therapist or a provider, or kind of on a community level. So really excited to kind of share some of this information with you today. So I'm going to start and share just like a little bit about me. One, I put, that's my cat Zelda, and there's Stewie, and there's my beautiful wife Julia. And I wanted to just share a little bit about me. I know sometimes, you know, when I go to these presentations, I'm like, well, what gives you, person on my Zoom screen, like the authority to talk about this topic? So a little bit about me is I love to cook and bake. I've been smoking meats for the past year, you know, which I think is typical. I think everybody has taken up some type of new cooking or baking hobby during the COVID pandemic. I also love coffee. I will be taking breaks to sip on this coffee. And Jean, I just want a piece of that cake she's eating. That's amazing. We went and ate carrot cake for our anniversary down the road. So thank you for that, Jean. I do live in Washington, D.C., but I am actually practiced as a licensed marriage and family therapist in Virginia, in the Northern Virginia area, is where I have a small little private practice, but I work full time as a product manager and focusing on clinical user experience at the Partnership to End Addiction. Basically, to sum that up, I really look at how to use technology to scale clinical services for people on a national basis. I'm also a certified substance abuse counselor in the state of Virginia, and I'm a volunteer with the Phoenix. That is a nonprofit that focuses on providing free fitness for people who have just 48 hours of sobriety. I will be sending out a link to the Canva directly at the end. And if you see down here, you'll see when I use citations and stuff, you can actually just click on this for redirects to any of the references. So Canva is really awesome that they started offering just like the ability to like plug in direct websites. Oh, and I see my mother has posted, hi Patty, great to have my mother here doing good work in Alabama. Okay, we'll keep it going. I don't know why the buttons aren't working. Okay, so I kind of wanted to start and share a little bit about my background when it comes to substance use. And when we talk about harm reduction, I think it's really important to focus on the personal story a little bit because it's going to elicit bias, right? So I'm not going to tell my whole story, but just kind of in a brief synopsis. Back in the day when OxyContin was super prevalent and easy to get, I certainly found myself using, but I also kind of consider myself a trash can. I enjoyed all types of substances, cocaine, methamphetamine, marijuana, alcohol, you name it. I did it, and I did it in abundance. And I loved that lifestyle, right? I really did. I found connection to substance use and connection to other people through substances. And, you know, I loved hallucinogens, and I was making dimethyltryptamine for a while and importing analogs and research chemicals. And I fell in love with the substance use world. I really did. And it meant the world to me. And interesting when I reflect back. I remember one time I was having an acid trip, and we're going to get very candid during this presentation, as if you haven't already figured that out. But I was using acid at one point, and I thought about, like, I want to have substances and drugs as a part of my life forever, right? It's interesting that that is actually really manifested, a decade later, and it's still been true that substances are still a major part of my world. And I say that because I learned a lot about substances. I learned a lot about how people form meaningful and intimate relationships with substances. I certainly did, and I met many people who cared a lot about substances, and then started figuring out that, hey, the rate and the frequency and the way we were using substances was not sustainable. Um, and so, oh, hold on one second. My alarm is going off. I'm so sorry, y'all. Give me 2 seconds here. I love the work from home world. My wife just left and the alarm was still on, and there was about to be all sorts of sirens coming through y'all's screen. So I saved the day for now, but to kind of just hop over, Remedy, I know I was like hearing that noise. I was like, oh no, something bad's about to happen. But I kind of, the main thing that I want to touch on is that I ended up going to rehab in 2012, and I went to a kind of 12-step based, abstinence based program, and they really focused on abstinence as being kind of the primary treatment modality. Knowing what I know now, there was no discussion of harm reduction, right? What were we told? We were told, go to meetings, get a sponsor, work the 12 steps. We were sent to meetings while we were there. I certainly had some great clinical contact while I was in this treatment program, but the focus for continuing care and the focus for the relationship that I had meaningfully gained for a decade was to cut that relationship off, was to engage in abstinence, right? And so that's what I was told. Luckily, I was kind of down for that. I kind of started to really realize personally that, substances led me to rehab and like not a lot going on for me. And I kind of wanted a different life for myself. And I could kind of easily make the connection that substance use was not going to lead me to a road of a life that I wanted for myself. Um, but a lot of people that I went to that rehab with, and a lot of people kind of in my life moving forward, substances, they weren't just able to cut that relationship off. And so over the years, and especially as I started showing up to helping people, I started realizing that for every person I help, there's going to be a lot of different factors in how they relate to substances and what their journey with substance use will look like moving forward. And so I say that as we go forward, my substance use experience brings me the bias of, I thought a lot about abstinence and that people should go to 12 steps and people, should go to inpatient treatment facilities is better than IOP, right? When I thought about harm reduction, I thought there's no way that somebody who was using heroin will be able to, successfully drink later in their life. So I wanted to ask just for a second before we dive in, what do you think of when you think of harm reduction? If you don't mind just kind of putting in the chat, maybe any associations, words that come up, thoughts or feelings. And I'll kind of name a few as they come through the chat. Meeting people where they're at. Yes, exactly. Very kind of person first approach. Safety. Absolutely. Prevention, that's a really interesting one. And I think that's a great point. Harm reduction has kind of multiple areas on the continuum, right? Self-care, I love that. Lesser of two evils. No judgment. responsibility towards others. These are great. Let's see, Gene, talking and communicating and remaining consistent, taking better. Oh, yes, I'm loving this. Finding balance. I really like that one. Finding balance and coping. Those are great. I think harm reduction comes up and brings up a lot of kind of feelings and emotions. And I can already hear kind of that person first approach in a lot of these kind of chats right here. So we're going to talk a little bit about background, and then we're going to walk through kind of what harm reduction looks like today. We're then going to kind of look at some of the core principles of harm reduction. We're going to take a little break, and then we're going to come back and talk about kind of harm reduction in action. How can we make this happen in our day-to-day? So starting with background, Timothy Leary, some of you might be familiar with him, especially for any of my kind of fellow acid hallucinogen heads out there. Timothy Leary was a kind of a very prominent, individual figure in the 60s, really focusing on bringing psychedelics to many, many different individuals. Really started working with just scientists, individuals who are finding problems, and then as well as individuals who are struggling with psychiatric disorders and using LSD there. Fun little fact, the double helix that we know from DNA today, that double helix idea in the structure of DNA came from an actual LSD party that Timothy Leary threw for a group of scientists that were really struggling. It was a group of biologists that were really struggling trying to understand the human genome. So when they were on LSD, they came up with the appropriate kind of DNA sequencing that we know. Over the years, though, Timothy Leary really started opening up for a lot of people and kind of really popularized acid in the mainstream. And in doing so, he came up with a thing called set and setting. Well, the history of Timothy Leary is outside the scope of this presentation. We look at set and setting because that idea around substances led to one of our kind of pioneers in harm reduction, Dr. Zinberg. I love that book on the left. If you need a book recommendation on harm reduction and kind of want to really start to understand the scientific reasoning behind why harm reduction has really exploded starting in the 1980s, there's both science and activism that we're going to talk about, and Zinberg really led the science part of it. So he expanded on Timothy Leary's ideas with drug set and setting. And what Zinberg really did, he was a Harvard researcher, and he looked at a lot at the data sets that came from the Vietnam, I forget what that super famous data set is, but it was basically how are all the Vietnam vets doing and what was kind of their experience from substance use to mental health to PTSD. And basically, there's this huge question of, hey, a bunch of people went to Vietnam, used heroin, and then came back, and yet the severe substance use disorder rates did not change. I forget what it's called at the time, but opioid use disorder rates actually really stayed largely the same. People came home and stopped using. Zinberg really focused his research on why. And what he found was that actually, based on these three variables, set, setting, and drug, dictates the frequency of use around a substance, right? So drug, type, frequency, amount, how it's taken, polydrug use, including alcohol and medicines. We're talking about the actual substance itself. Set, gender, age, mental health, physical health, reason for use, knowledge, experience. We're really talking now about the individual. Their biology, how they interface with the world, their emotional and mental health, developmental health, and then setting, right? We might know this today as kind of environment. What is the environment that they're using in? And what he saw and really kind of learned after doing a lot of qualitative research, kind of post a lot of his quantitative work, is he saw that people, when you would interview them, would come home and stop using heroin and start just drinking alcohol on the weekends. Maybe they would develop an alcohol use disorder, but no longer cared for opioids. Some of them were just using marijuana. Some of them came home and didn't care that much about substance use at all, right? So he started learning that a lot of people, when they would change either their set or their setting or the drug, that it would have a different effect on kind of how they interfaced, or really what he narrowed it down to is they would develop a new relationship with the substance use. Drug set and setting is probably one of the more prominent kind of theories with harm reduction, really creating a case that there's multiple pathways, right? Something that I think we've really focused on as MAT has kind of blossomed over the past decade as a response to the opioid and really addiction epidemic that we have been faced with. And so we look at Zinberg's work and we kind of fast forward a little bit into understanding kind of where we at today when it comes to history. And I found this quote, this wonderful researcher did almost kind of like an anthropological overview of harm reduction in the United States. Here, when I send the link, you'll see you can access the whole journal here. It's very thorough. It's really wonderful. But I love this quote, and I'm just going to review it real quick. Harm reduction has a very complex history in the USA. The USA has led the world in developing some aspects of harm reduction, like methadone and buprenorphine assisted treatment for opioid use disorders. But the US federal government was for a long time a fierce opponent of harm reduction, both domestically and internationally. The history of harm reduction in the USA is best understood as a conflict between multiple conflicting social and historical forces. The two most important forces promoting harm reduction in the USA have been activism and scientific research. The role of activism has been very well described by Moore and Clear. There have been a great cooperation between harm reduction activists and HIV/AIDS researchers over the last 3 decades. The activists were typically in the forefront of the struggle to implement harm reduction. The researchers then provided the data needed to justify large-scale public expenditures on harm reduction programs, primarily by state and local governments. Without these public expenditures, the harm reduction programs would not have achieved the scope they needed to be successful to stop the HIV epidemic among people who inject drugs. PWID is a common acronym you'll see for people who inject drugs. So let's talk about that for a second. There were 2 major things that happened in the 80s. HIV epidemic, and the response prompted the scientific community to show up to the HIV epidemic to start to figure out how can we better navigate this. There was also a huge overlay with people who were using substances that also were getting infected with HIV. And so in the 1980s, we kind of see, methadone was there, but really kind of in the background, starting in the 60s. And in the 80s, we start to see this huge kind of push for harm reduction strategies on both the substance use world, as well as for the infectious disease world, right? Really looking at, and that's why it became a public health kind of focus. And really what people started finding is that research, when it came to kind of offering like clean needles for people, when it came to offering kind of, syringe programs for people, when it came to offering better education programs to people that are actually in communities, not in kind of the ivory towers, they saw that actually you would have significant reductions in both overdoses as well as rates of HIV. And really, if we look at kind of the public health policy and public expenditures, the 1980s is where we really see it start. Yet at the same time, I think everybody here probably is well aware of the absolute demonization of substances in American culture. Think about how we've talked about marijuana forever until only recently, and still plenty of people are debating around marijuana. There was a great meta-analysis that was done. I think it was 2014, it was published on what is the most harmful substance. If we were to look at, kind of all the literature that is out there on all types of substances, from nicotine to caffeine to alcohol to heroin to meth, can we rate which is the hands down most harmful substance? Alcohol, hands down, was the winner. Heroin was about 20% less harmful, being number two, and then just about every other substance down. And this was a very, very well, it was a massive meta-analysis. I think it was 1,500 articles that they looked at to kind of come to their conclusion. And so let's think about that for a second. Alcohol, when I go to my Trader Joe's, there's an entire lane dedicated to alcohol. Yet when even, as marijuana becomes legal, it's still done, behind chain doors and a bunch of security cameras. And then you start offering any other substances, and there's such a heavy stigma to it. And so when we talk about the conflict, one of the biggest things that we talk about the conflict is the demonization of other substances other than ones that we dictated are okay. And so what we kind of find is that harm reduction is really being caught in the middle of that. When we start talking about kind of modern harm reduction practices, we see that it's really stuck because of the stigma that is associated to substances, most substances. So as we move forward, what does harm reduction look like today? Well, we have micro and macro approaches, individual approaches. We're going to talk about peer support. We're going to talk about clinical modalities of harm reduction and motivational interviewing. And we're also going to talk about community approaches. I will say I am a strong proponent of harm reduction, but when it comes to community approaches, there are people much more well-versed in the actual implementation. So we're going to kind of do a very high level on community approach. But I will also have lots of resources there for you later to kind of think about how, from a community perspective, you can implement some that make sense for you. So also, public health funding has slowly started prioritizing harm reduction approaches over abstinence approaches due to the increasing deaths from substance use disorders from the old approaches. Basically, so this on the right side over here, about 2 months ago, the current administration started actually adding it for the very first time into the White House budget. You can see here, I kind of zoomed out, ensuring access to harm reduction services such as syringe service programs. We also have a very interesting one, equitable enforcement of drug laws and access to treatment. And when we think about that word equity, that is a large kind of focus of harm reduction in general as well. So for the very first time on a federal level, there's actually a federal response. If you remember back in the history, it was local and state level. But now we're starting to see a federal kind of focus as well. Right now, it's kind of on the research, but even on the initial proposed budget, I want to say it was close to $25 million per state was the initial budget was going to get focused on harm reduction services. That's been whittled down and kind of the negotiations that have been ongoing, but we'll see what that looks like, right? It's now becoming a priority because people are still dying. And I think that's kind of one thing is that, I don't know about y'all, but I'm tired of seeing people that I care about or know about or reading. People are still dying at unprecedented rates. We will see what this year's numbers look like. I will be shocked if we see if it's maintained the same or gone down. I really do believe we will see an uptick, and having worked in kind of a national setting for some years now, it's kind of the same response that we're seeing. People are still dying from opioids and methamphetamine, as well as other substances that are laced with fentanyl or using them very risky in a risky setting. And then I do kind of want to touch on the last two. Harm reduction still trying to find its space, especially in the American substance use disorder ecosystem. And it's often seen as an opposition to abstinence. If you leave this presentation and you've learned nothing else, I do just want to offer that harm reduction and abstinence absolutely work together. And I will give some case examples of what that might look like. as well. And many individuals associate only the most progressive approaches with harm reduction. Example given, safe consumption sites. I'm a proponent of safe consumption sites. I will explain my rationale later. However, that's a big stretch for a lot of people. Even when I meet with very kind of progressive substance use disorder providers, that's a tough one, right? How are we going to facilitate the actual use of substances for people? Doesn't feel great, right? But there are a lot of different ways that you can show up to harm reduction in a community and on an individual level. And so I would imagine actually, and even seeing some of your responses in the chat, a lot of you are already harm reduction, utilizing harm reduction approaches in your work. It just might not look like kind of some of those more progressive options. And so what is harm reduction? This comes from Harm Reduction International principles, person first approach. We put the person at the front of the work that we do with them. The substance is ancillary. We do not make the substance the focus of the work. We make the substance ancillary to the person. People are not their behaviors, right? I did some really rough things when I was out and using. Am I defined by the behaviors that I did? Am I defined by the behaviors I do today? I hope not. I hope that people, are able to look at me as the person that I am and really see myself as an individual with values and beliefs and a set of morals and a set of personality characteristics and a way that I kind of present myself. I am not only my behaviors. And we respect the rights of people who use substances. People who use substances are not bad people. And I say that by just looking around at all the people that I love that drink alcohol. I respect their rights, right? So how can I continue to kind of maintain that same compassion and love and support to somebody who might be using cocaine or might be using ketamine or hallucinogens, or maybe is really struggling with opioid use disorder? We respect the rights of people who use substances. A commitment to evidence. So when I go back and I say that I'm a proponent of safe consumption sites, and a lot of people are not for that, for me, a commitment to evidence means looking at the data and looking at what people are researching and implementing that into my work. When I see that consumption sites lead to 5 times greater likelihood that somebody will actually enter treatment versus somebody, a control of somebody who's using the same substance and is not going to a safe consumption site, I choose to believe in safe consumption sites. It's a commitment to evidence. If somebody came to me and said, actually, Jack, we recently did a meta-analysis on all harm reduction strategies in comparison to individuals just showing up to 12-step meetings, and you know what we found? That there was a huge effect sample on the size that or on the side that went to 12-step meetings. That is way better than trying any of these harm reduction strategies. Then being somebody who's really in the harm reduction approach would need to look at that and really integrate that into our approach. And then lastly, the avoidance of stigma. One example that I give is, there was, for a while, looking at fentanyl, there was a lot of kind of fear mongering going back to that demonization, where there was kind of a famous story of a police officer who was exposed to fentanyl and entered withdrawals after being exposed. Well, there were actually a ton of articles that came out about that. So Harvard Toxicology did a report. The SAMHSA and NIDA co-published a paper on that event, as well as the records of the toxicology report that came from that police officer were all released, and it showed that actually that fentanyl cannot be transmitted in a significant amount. So bioavailability around transdermal exposure is actually not possible for fentanyl. The only time that opioids have actually been bioavailability, had enough bioavailability to show up in a toxicology report was actually in an Afghanistan study where young children that were sitting in opium dens in Afghanistan that were around opium smoke 24/7 for multiple days at a time actually had opioids in their system. Outside of that, bioavailability from opioids only comes through injecting intranasally or orally. So we learn these things, right? Stigma comes from flash judgments on a substance, and then what happens, fear starts to set in, that protection mechanism where we need to protect ourselves and feel safe. And so fear brain kicks on, and I start to associate negative stigma to substances. And then all of a sudden I start to make that same fear to the people that are using those substances. It takes a tremendous amount of work to avoid stigma. That is one of the principles of harm reduction. So what are our goals? Reduce the harms of drug laws and policy, right? When we think about equity, especially when we look at how many Black and brown people are currently incarcerated as a result of drug laws, harm reduction fits really wonderfully into the kind of world of equity around race and ethnicity, diversity and inclusion. Keep people alive. I'm sick of people dying. If that means somebody needs to be on methadone or buprenorphine so that I get to go and hug them and call them later, sounds like the right option for me. And we encourage positive change in their lives, right? That's the focus. What is it that you want for yourself? And we'll talk about that a little bit more on some of the clinical approaches. And we offer alternatives to approaches that seek to prevent or end drug use. That is still an option. We're not saying that, we shouldn't get away. I'm grateful for my sobriety, for my abstinence. Yet at the same time, there are 7.5 billion people in this world. And I will say a lot of people that I work with, you offer abstinence, and they're going to tell you 101 reasons why that won't work for them. So we offer alternatives to show up to those people. I think somebody said in the chat earlier, meeting people where they're at. Offering alternatives is one of the major goals. So we're going to talk about a principle here. This is probably my favorite principle of harm reduction: safe versus safer. A lot of times in harm reduction, we tend to think of, okay, we're making drug use safe. Is that what we're doing? Absolutely not. We're making it safer for that individual. And if we think about it, what's really safe, right? I live in DC, I walk everywhere, and I think all the time about how many people get hit by cars right outside my house. Somebody got hit by a car. Like, I'm looking at the intersection, right? Just walking in my neighborhood. Safe? No, not really, but we can make it safer. I'm going to ask some people to put in the chat. Let's think about this one: safe driving versus safer driving. What are some of the ways that we make driving safer? What are some of the strategies that you've seen that makes driving safer? If anybody wants to add anything in the chat. Seatbelts, yes. Checking mirrors, right. Slow it down, right. Not being aggressive. Bluetooth phone calls. Oh my goodness, there's so much good stuff in here. Following traffic lights. I got like 3 of them in a row. Backup camera. Oh my goodness. I was in a car without a backup camera like 2 years ago, and I hit a car, right? I'm so used to the backup. Stop texting while driving. Yes. Lane assist, paying attention. All of these things are absolutely ways that we make driving safer. Driving is never safe. I have a friend that does like traffic research at Emory, and he was like telling me that driving is one of the most wildly insane things that we can do to put ourselves in a tremendous amount of risk. However, driving provides a ton of benefits, right? Safe driving laws, sensible laws around driving, because we still want to honor those benefits that driving provides us. At the same time, we want to make it safer. We just had a huge, DC's had a problem with children being hit recently while walking to school. So there is a huge campaign around safe driving laws and enforcing no more than 20 miles per hour around schools. And it's very, very intense how they've kind of rolled that out recently. And then lastly, I saw a lot of people, technology can really show up to safer driving, right? And I think we see that kind of in the future when it comes to autonomous cars, as well as, just looking at now, ways, giving better alerts when you need to take a rest, Being able to really prompt you to slow down if you're going over the speed limit. I even saw one where they were kind of able to measure based on eye input how tired somebody is, and to give you kind of some notifications. We have a lot of strategies on how to make driving safer, so we'll bring it over to substances. Drug use is not safe. From nicotine to caffeine, hence my coffee, to heroin, methamphetamine use, using research analogs that are technically legal and way more potent than a lot of substances that are out there right now. Safer drug use. Well, if we think about kind of to our car example and all those options and opportunities that we use, think about the same for safer drug use. What do we do to make drug use safer? I would be happy if anybody wants to offer any suggestions in the chat that they've seen or are kind of thinking about. But I will just say some of the ones that I've seen are, really prominent public health campaigns around how much you should drink at a single time, right? I think about all those like little pictures of like 1 shot equals 2 wine glasses equals like 3 beers or whatever, and really focusing on not drinking and driving. I see I think it's Mike, needle exchange programs, informed care are 2 great examples. And then also, if we start thinking about safer drug use, one of the best things that I found is actually just talking about it, naming what is it like for you to use substances, how much did you use. We go way back to our drug set and setting, asking them about the drug set and setting that they're in. What are your motivations for using substances? Are they around connection and social events? And do you feel like that you're able to stay within your boundaries, or do you feel like you're pushing your boundaries every time that you use? We can talk about safer drug use from the policy level to using technology, to creating more sensible laws around drug use, to offering, as Tori just said, treatment instead of jail, down to kind of the micro level, really just looking at an individual's reasons and motivations and how to show up to this behavior in a safer way. Same reason, right? Road rage, big problem if we try and cool down. So throughout this, I'm sorry, I got a little bug right here. Throughout this presentation, I have a couple just little stories of harm reduction throughout my career so far that I wanted to share with you all. I saw a couple in their mid-30s for about 2 years. Primary complaint was that he was drinking significantly after they had their first child. That's kind of what prompted them to come see me. This drinking resulted in a hospitalization and his wife threatening divorce. The individual, over a period of time, the male, committed to a mantra of personal health and family relationships. Part of this commitment was no drinking for 6 months. So we started meeting, we were talking. He said, you know what, you're right, drinking has not really served me well right now. So I'm going to hit the brakes for 6 months, and I'm just going to see what happens in my life. After 6 months of no drinking, he started to really feel positive effects as a result of this commitment. And he wanted to maintain this positive feeling that he got. So he created a set of boundaries that he communicated to his wife regarding his alcohol use. No more than 2 drinks on Friday after work, and 3 drinks on Saturday, but never back to back, meaning he could either choose Friday or Saturday, but he wasn't going to do both. And that was communicated, and he talked through this with his wife, and he really kind of focused on her experience in creating space. And a lot of our sessions are also creating space to say, like, that was really hard in the past. What does it mean for you to kind of go back to drinking now? What does that mean for our children? What are we modeling around substances? Was it perfect? No, I saw them for a long time. It was absolutely not perfect. But what happened? Each time he pushed his boundaries, there was probably 2 or 3 times that he set the boundaries that he would really push past. And one was pretty significant. It was his own opportunity, though, to learn from it. These were his boundaries, right? And then how did his wife get to show up to it? His wife got to ask, I know these boundaries are important to you. How do you feel about pushing past them this past weekend? Think about how different that is than when he came in. How dare you drink when we have a newborn child? how could you do this to me? Now you're hungover and now I feel like I'm a single mom right now. She was mad about his behaviors, and all of a sudden now, because of a lot more understanding about why drug setting are important to him, what his motivations were around drinking, what her experience and her family of origin said and thought and experienced around alcohol, and how when they kind of interacted together, what alcohol meant to them, the couple changed from triangulating alcohol to externalizing a set of understood goals and boundaries and working together to support these goals. This was a harm reduction approach used in a couple's context to make the behavior of drinking safer for them. We didn't get rid of use. And actually, I wasn't going to put all this in here, but abstinence in that in his family had a lot of really difficult connotations around it. Going to AA had a lot of difficult connotations. He was open to it, went to all of it, but it wasn't going to work for him in the time that he spent with me, at least. I love the story. It's just kind of a moment to think about. This is a form of harm reduction. We made their experience as a relationship and his individual experience safer when it came to his alcohol use. So kind of just a few more, and then we'll take a break here, about 10 more minutes or so. A theoretical background, and I know somebody mentioned this in the chat. Let's see if I can bring out their name for a second. I see Han meeting people where they're at. That's going to really speak to this. And I feel like there was one other. And Angelia, taking baby steps. Theoretical background on this, we call it the stages of change model. I'm imagine many of you are familiar, but I think it's always a good grounding place to be mindful of. People enter a place of pre-contemplation around any behavior change and go through a cycle of change when it comes to any relationship that they have. I always give the example of coffee, my cup of coffee right here. If my wife came to me tomorrow and said, hey, Jack, you know what? Your coffee consumption has to stop. Spending way too much money on it. Honestly, I feel like it takes away a lot from your life. I know it's staining your teeth. And to be honest, I think it has a negative impact on how you kind of show up to our relationship. You tend to be on edge after you drink coffee, and I don't really like that. And I might say to her, I love coffee. In fact, coffee is the only thing that really kind of gets me through the day right now. In fact, what I'm going to do is I'm going to tell her all the reasons why I'm not drinking or not going to stop drinking coffee. I'm in pre-contemplation. But let's say the next day I drank too much coffee, and then I went to work and I felt really jittery and I didn't eat lunch, and I just felt like, you know, for whatever reason, I was overstimulated and I wasn't able to do my job that day. And I really like my job and I want to be able to show up in a meaningful way. Internally, I am now contemplating the effects of coffee on me. And I'm actually kind of taking some of those seeds my wife planted. She didn't hear that. Now this is an internal process. Well, maybe that goes back and forth a few times, right? I'm not necessarily ready to make a change. So I kind of go back to pre-contemplative, but I have another one of those days and I'm, yeah, I got to make a change here, right? And maybe, you know, I actually say, I'm not going to totally stop drinking coffee, but what I'm going to do is I'm going to drink half the amount of coffee. Well, that's determination. And then the next day, I actually drink half the amount of coffee. That's an action. But let's say I'm just really tired the following day, and I might go back to the old behavior. I had the same amount of coffee. I actually don't totally love this one because relapse can be optional. We actually see action can lead to sustained or can fork out to relapse and keeps you putting in the cycle. But the idea is that behavior change comes through a process of testing, trying it out, going back to the old behavior and learning, going back to pre-contemplative and starting cycles over again. And we see change, even with long-term change, we see as kind of a cycle of going to pre-contemplative for the next step of change. Maybe it's, I totally want to get coffee out of my life. I made this change. I'm drinking half the amount of coffee. I'm still feeling a little odd some days. I'm back in the circle of pre-contemplation though. I already gave up so much coffee, right? Harm reduction is about meeting people where they're at within their stage of change. Keep going forward here. So when we think about, I'm sorry, I've got things on my screen right here. I'm trying to minimize. There we go. When we think about kind of the expectation versus the reality of helping people when it comes to substance use, an expectation, I'm going to show a screenshot from a SAMHSA created, SAMHSA, and the Addiction Society of Addiction Medicine, ASAM, created kind of their full continuum of care manual. And I'm going to show that later. And it is all focused on abstinence. A lot of the existing models that we have are really just focused on abstinence for people, not really meeting people where they're at. If we look at the expectation, somebody comes in and having worked in a lot of different facilities at different levels, right? The expectation is that they come in, depending on their initial assessment, at a certain level, whether that is a high intensity residential service, right? Or clinically managed low intensity residential, a PHP setting, an IOP setting, and then they work downwards to zero. The idea is that the continuum of care, you come in at a certain place, we measure and evaluate, we might bump you up, we might bump you down with the end goal of moving to zero. And if you look at how zero is defined, it is abstinence and the maintenance of abstinence. That is written in just about every major federal guideline that insurance companies live and breathe by, is the movement towards abstinence and the maintenance of abstinence. What's the reality? If you have met with people and you are talking with them, whatever field you are, from seeing them in kind of a first responders case to supporting them as a peer support agent or working in one of these settings, I'm sure all of you have seen the very, very stark contrast to the expectation, which is the reality is that stages of change model. I might have somebody verbalizing to me, I plan on not using heroin today. And then they come back the next day and they said, I used last night. That means that they're in a determination phase. They weren't able to step to action yet. I might see somebody saying, you know what? I'm just not ready to quit drinking. I have really no desire to quit drinking. I hear that a lot, pre-contemplation, right? The reality is that people are in, for whatever reason, their own stage of change. So the challenge with harm reduction is moving from expectation to showing up to the reality is really what we're trying to do here. So when we think about harm reduction, I always think about two things. The person matters and the substance matters. What does that mean? Well, let's go back to you for a second. What is your own story with alcohol? How did you learn what alcohol is? What is your family's relationship with heroin? Now it's a typo from an old version. Did you try alcohol? Did someone you love try alcohol? How was it? When was it? What type was it? Where were you when you tried it? How old were you? I have found over the years, when I do especially family interventions, I start with this question. What is your own story with alcohol? Instead of focusing on everyone else's behaviors, especially the in craft, we would call them the identified patient, but the one that's everyone's focused on, right? What is your own story with alcohol use? How did you learn about it? How did that relationship change over the years, and why did it change? I met with a family pretty recently, and they were really focused on their son's 18-year-old son's marijuana use. And I asked his parents the question about marijuana with him in the room. And I said, how did you learn about marijuana? When did you first learn about it? Did you ever try it? Both of them had. His father was actually still, from time to time, still using it. They talked about how at times they used it more frequently and at times they actually weren't using it. And we talked about all the reasons for that dance of using marijuana, not using marijuana, and what caused the change in frequency. And that conversation allowed their child to then show up to the conversation as well with his own story. So we think about the substance absolutely does matter. And We also think about, and I referenced this again because of the drug piece, right? What we're really talking about is the drug itself. And so while the substance matters, I'm going to go over to the person matters. I'll come back to that one. We also want to give a lot of focus on who that person is, right? Harm reduction is about focusing on the values and goals of a person while providing a safer environment for them to build up to the things that are important to them. Everyone is motivated for something, and it is your job to support development and growth individually as a person. And one thing that we'll kind of talk a little bit more when we get to kind of some of the clinical work is tapping into somebody's motivation can lead a ripple effect. I've seen it all the time. If you've ever kind of shown up to somebody, what is the smallest, tiniest piece of behavioral activation you can make them do towards a healthier behavior? And if they can make that jump, you will see them really blossom into other behaviors that they didn't even think was possible. Sometimes I like thinking about exercise, right? That getting into a gym or going on a run when you haven't gone on a run or gone into the gym or whatever it is that you like to do, that first step into the unknown is the hardest step to take. But all of a sudden, if you can kind of build motivation, what are your reasons for wanting to go and exercise? And they can take that first step very quickly can lead to a second step. So when we think about the person, let's really think about what's important to them. And that is probably my favorite question that we focus on is when somebody's using substances, get out of the substance and focus on what do they care about. And I also want to go back to something I kind of started with my own story is people have incredibly intimate and personal relationships to substances. They might love their children and they might love cocaine. And you think that's kind of crazy, right? How can I love a substance as much as I love my child? But I have met people that will tell me that day in because they feel like that cocaine has been the only thing that has provided them consistent comfort and safety. That's their experience, right? Relationships, though, can and will change, provided the ecological setting and intrapsychic forces, fancy words for just saying maybe the environment change, that set or setting has a change, then relationships can also change to the actual drug. And every individual has a unique relationship to substances. Go to a 12-step meeting to confirm. If you think a substance, a drug is a drug is a drug, it doesn't matter. Go and listen to a 12-step meeting about all the different relationships that people have had to even just the same substance of alcohol. And relationships can go between harmful and helpful. So when we think about harm reduction and we think about starting to show up to people and supporting people, we can think about relationships and the person that we're working with, they matter, and the relationship that they have to substances matters. Both of those things are areas that you can pull from and change and modulate to create a safer experience for them. And I think we are yes, I'm going to go through the story and then we're going to take a quick break. This one was really heart-wrenching for me. I worked with this father for a while, single parent household. They had divorced quite a while ago and she didn't want to be a part of the family's life anymore. And he had a daughter on Suboxone. I do tend to use slang because slang is going to be kind of your best entry point into the harm reduction world. He had a daughter on Suboxone and the weaning and using heroin, would go back to using heroin after she would wean off Suboxone and then get back on subs for about 5 days and then kind of started over again. And he was referred to me after his daughter left inpatient treatment for not being med compliant because of this kind of back and forth cycle. And he just couldn't ask his daughter to leave the house. When we think about boundaries and enforceable consequences, he was not going to enforce it, asking her to leave the house. And so because of that, I asked him if he had Narcan. He told me I'd never heard of Narcan. His daughter had been using heroin for about 3 years and he had never heard of Narcan. That's a harm reduction approach. And I want to be mindful that there are really small ways we can show up and offer safer drug use from a family, community, and individual perspective. So we're going to stop here. It's 1 o'clock on the dot. I have a few more slides. I'm going to come back in 5 minutes. I'm going to get a cup of water and eat a banana real quick. So I will be back. It's 1 o'clock on my end. We'll say I'm going to start back up at 1:05 pretty sharp. So excellent. Be back soon. All right, everyone. I have 105 and John asked a great question. Why is the person's relationships with drugs important in harm reduction therapy when the reason they're presenting is because of drugs? John, it's a great question and kind of what we would offer, right? When thinking about harm reduction is thinking primarily about relationships can change, but we have to understand the nature of somebody's relationship before change is really going to be possible, right? And so if somebody is coming to you, saying that I just really, I really feel great when I use heroin. It's the only thing that I've really found has worked for me. Spending a lot of time understanding their relationship to heroin. When did it start? How does it make you feel? Have there been any difficulties in that relationship? What we're kind of trying to do is starting to dictate what we might call their decisional balance or eliciting ambivalence around the relationship that they're having with substances, right? I find it very rare that somebody who's kind of saying, I'm using the substance and all is good, that there's also not some difficulty on the other side. As a clinician, I know sometimes you might know what that difficulty is, but sometimes you don't. So really kind of bringing out the relationship and the story can help kind of give an honest view of the role of that substance and the relationship they've had with that substance. But we're going to keep moving forward. I added some myths here. When we look at research kind of right now for harm reduction, there's a lot of myths out there, right? So just a few of them: harm reduction, supervised consumption sites and policies like decriminalization will enable drug use. Maintenance medications for treatment of opioid addiction simply substitute one addiction with another. A drug is a drug is a drug. Responding to overdose calls with naloxone is a waste of police resources. There's no quicker way to fire my blood up than talking about that one. At its base idealistic level, giving somebody another day, a shot in this world to show up and live and engage in their values is enough for me. I'll spend my taxes a million times over to make sure that that happens. Syringe exchange programs encourage and enable drug use by making it easier and safe. So these are just some of the myths, right? And why we talk about these myths is there's actually been a lot of research on every single one of those things. If you look at, again, here's a little reference here from Filter Mag, and it's a great article. I think 2 or 3 of these come from that individual article. And then on references, I also have articles that really kind of go into every single one of these myths and kind of what's the reality from research that we've seen. So the why behind the what. Why do we do harm reduction? Why do we, when we start thinking about ways to implement harm reduction, why do we do this? This is just a few findings that we've had. Right, according to the CDC, people who inject drugs are 5 times more likely to seek and receive treatment for a substance use disorder if they're participating in a sterile syringe access program. One of the things that we see harm reduction programs offer is that it's a moment in their life where the substance use is not too taboo. They can show up to it. They can talk about it. They can start to have an honest dialogue about what's going on for them. Right? All of a sudden, we're both talking about that you're going to go and use heroin today, and you really miss seeing your children. That starts to flesh out that ambivalence. We're starting to focus on the person and the substance in that moment. 23% of people who were interviewed for one study related to Insight, North America's first sanctioned supervised injection site, stopped injecting, and another 57% entered addiction treatment. So what we're looking at is that, especially on that community level, we start seeing that we can kind of intersect and really meeting people where they're at is saying, I'm going to go and get high today, but I'm going to stop by and get some of my clean needles. Hey, and if you're ever interested in treatment or maybe some Hep C treatment, This is a pamphlet on where to get that near you. Families using CRAFT approach saw a 60% increase in treatment completion using harm reduction approaches to family support, right? So when we think about harm reduction at the family level or relational level, people start to engage not only in treatment. Johnson intervention is great at getting people into treatment, terrible about seeing people finish treatment. But we want to see people engage in treatment, go to treatment, engage in treatment, and complete treatment. We see harm reduction really increases the rate of engagement and completion of treatment. And then if you look at Portugal, I put, Portugal is probably the best, long-term kind of study that we have. And y'all, where they just fully decriminalized. I mean, Portugal is really killing it. Their rates of substance use disorder are far below our kind of 9% threshold that we see everywhere, as well as kind of poly substance use, other drug use other than just opioids and methamphetamine, as well as overdose rates are all down, way below what we see here in America. So the why behind the what, I added, I think, 3 references here. If you really just want to nerd out and start trying to figure out, why is harm reduction kind of this burgeoning thing that we start to hear and see? It's really because of the research with a little bit of activism. Right now, people in vans going out and handing Narcan syringes is what harm reduction looks like today in a lot of cities. But the science behind it is actually pretty sound, right? It's not perfect, and there's areas where there are no kind of major effects noted, but overall there tends to be a lot of kind of positive outcomes from the research. So harm reduction in action. I know we spent a lot of time in the background, so let's get into how we can start making this happen. So I figured the best way is I'm going to talk about some interventions here. And this is kind of, if we think about, we're going to start with clinical intervention and peer support interventions. So this first one, I pulled all of these from cases that I've worked with. We're going to talk about a 22-year-old white male, currently in college, was in an IOP dual diagnosis treatment, bisexual, high acceptability of substance use on paternal side with low acceptability on maternal side. And his stated substance-related goal is to reduce his Adderall and alcohol intake. I'm going to read this, and I'm going to tell you that this is an experience that I had as a clinician. Obviously, I changed all the demo information, but client comes into session, and he shares with me that he had a successful weekend in regards to his alcohol and Adderall use. He took his Adderall as prescribed. That was a major boundary that we had worked on for months, right? He would always kind of double dose and triple dose at times when he was feeling really stressed, and stayed within his boundaries of only drinking 5 beers one night throughout the week, right? We would meet every week. Session progresses, processing his experience, right? And really trying to keep the session focused on him. And at the end, well, it sounds like you're feeling really positive about the past week. Do you feel like you are committed to another week of staying to your goal? Guys, I can't make this up. He says, absolutely. But my boyfriend got some acid and we are planning to use, but I'm planning on not drinking. I cannot make that story up. We just had this amazing job. He has been processing all of this substance use work. And he says, I'm going to use acid this weekend. And as a clinician, I'm like, oh, right. I thought we were making I thought we were seeing, but what was I doing? I was bringing in my biases that I thought we were moving towards abstinence, and he was focusing on just his goals. I forgot about just his goals. He's actually talked about using other substances in the past and that not being an area of issues for him. So, as a clinician, to start with, how can I respond? Well, I would ask some follow-up questions, and it's clear that the determination is that he is absolutely going to use acid, right? There's no ambivalence there. I'm not identifying anything. So how would I approach as a clinician? Well, initially, to kind of start, elicit ambivalence and identify if there is any. How would that look like? I might ask him a question of well, do you mind sharing with me a little bit about how you're feeling about using acid? this weekend? And he might say, I feel fantastic about it. I'm so excited. My boyfriend and I, we've already made a whole plan around the weekend. What's that kind of indicating to me? That he has already resolved his ambivalence. But he might say to me, hey, I honestly, I'm a little worried about it. Last time I used acid, it wasn't great. And I felt like the only way that I could kind of, get out of it was to drink a little bit. And I don't really like, I'm trying not to drink and I feel like it's going to screw up my sleep schedule, but my boyfriend really wants to do it. And I told him I do. Right. So all of a sudden, we're now starting to hear a different story. So my first kind of inclination when using a clinical kind of more outpatient harm reduction is always start, is there ambivalence, which leads to two, determine level of commitment to use. If there is low commitment or ambivalence is present, focus on utilizing motivational interviewing to flesh out the ambivalence and to identify alternative behaviors. So we would sit with that ambivalence, right? Well, why is it important for you to kind of, do this for your boyfriend, even though you feel like it's kind of, pushing past your boundaries? Might be a good question to kind of identify. We can also look at some using darn language or Orr's language to kind of heighten his experience with both sides of those scales, right? And kind of which one has more motivational kind of balance to it. And if we see that he's actually, I'm 100% excited about this, I'm going to use, and we see if commitment is high, then we would switch over. And this is really kind of the true harm reduction focus, is we would ask question about a current use plan, right? So when, where, with who, dosage, and how does he feel about using? Another question you can also ask about is past experiences of use. What has he learned from using from using acid in the past? Were there any positive experiences, and what made them positive? Were there any negative experiences, and what about those experiences made them negative? Who does he use with? Is it just his boyfriend, or are there going to be other people there? Where? You said you had some plans. I would love to hear, what are some of those things that you're hoping to do this weekend? And when? When are you going to do it this weekend? Have you kind of thought through, the environment? So what are we doing here? We're focusing on the drug, set, and setting. And so how we might make this use safer, I might offer, hey, I know you've been working hard on your goals and wanting to sleep better and feel healthier. How do you feel like you are going to honor that goal of being healthy while using acid this weekend? What I'm doing is I'm really trying to challenge on a clinical perspective, because I am not going to offer how to do that, right? What we want to do is we want to give them ownership of ways to make their own substance use healthier or safer, so that they'll take ownership in that behavior. From a clinical perspective, we want there to be engagement in the solution that they elicit. So what I'm doing here is I'm really focusing on something that he has stated is important to him, of his goals being able to sleep better and feel healthier, whereas kind of primary goals from Adderall and alcohol use. How are you going to honor that while still doing this behavior you're also committed to? So what we're doing there is we're really keeping it to them, and ideally we would start to elicit solutions from them, and then from those solutions, then we would elicit a commitment statement around, what he might feel. He might say, what, well, I'm not going to drink alcohol, but I think maybe one thing that I can do if I'm feeling, a little paranoid, is I might, last time I had a really bad trip and I didn't have anything to kind of calm down or cool down. Maybe if I had some marijuana, that would help me. Another thing that might be helpful is actually, we have a friend who, he doesn't like doing acid or anything like that. Maybe we can call him to have him present. Then we would elicit, what is the likelihood you'll follow through on one of those two solutions, and move forward. How can we make this use safer using these solutions? So really, as we think about this, if we identify commitment to the behavior of using substances, then we step into clinically creating an environment for them to create solutions for how they will make their use safer. And then we finalize with commitment statements around, or we can elicit a commitment statement around how they're going to make their use safer. However, let's switch our hats for a minute. Taking clinician hat off, putting on peer support hat. We ask some more follow-up questions and it's clear he's going to use ACID, right? On a much smaller scale, right? We're not sitting here in the role of clinicians. Now I'm just a community member. I am either a friend, I am a certified peer specialist. I know in Virginia, we have like qualified mental health support professionals. So I'm kind of sitting in that lane, right? I was a counselor tech. Counselor techs are just peer support specialists. So we ask some questions and we determine level of commitment to use, right? And if we're just hearing I'm 100% going to use, then we ask questions about the current use plan. Again, I'm thinking about coming at this from a harm reduction perspective. If I was wearing my abstinence hat, I might really try and lean on, hey, you could call your sponsor, or like maybe you go to a 12-step meeting, or maybe go into a smart recovery meeting tonight and reach out to them, or maybe do some meditation if we're doing recovery dharma. But if we're using harm reduction, we would ask questions about the current use plan. All right, you're using acid this weekend. That's cool. Who are you going to use with? Is it just your boyfriend? Hands it back to them. They will clarify for you, right? Well, how many times are you going to take? You know, do you guys already have it? Are you trying to find it right now? You know, how are you feeling about using acid this weekend? Just ask that question straight up. Right now, we're starting to elicit their relationship with substances. And then as a peer support specialist, I might actually offer a solution. Clinical hat, I would elicit solutions and commitment statements. Peer support hat, I would say, hey, I totally get that you want to trip with your partner this weekend. Makes sense to me. Shit, if I could, I would use acid too. You know, but honestly, I don't find that that's the best thing for me these days. You know, I've been in recovery for a while and I just try and not use hallucinogens, but do you know if there's going to be somebody that's not tripping with you guys? I know we always would try and have a sitter with us when possible, especially when things got a little dicey. I'm handing back a solution as a peer support specialist to see how they might respond to it. There might be a lot of different solutions that I have here. Maybe if they say, we don't really, you know, nobody's going to come and sit with us, that's not going to happen. Well, could you identify somebody? Do you think there's somebody you could call? Kind of have them, you know, at least tell them that you're going to be tripping this weekend and ask if you could call them. I could do that, right? So in the peer support role, we really focus on offering solutions that are focused around safety, when in the clinical role, we're really trying to elicit safe suggestions while pushing towards commitment around those safe suggestions that they come up with. So I kind of want to talk about support goals for a second, because one thing that we tend to do in the clinical world is we tend to focus a lot on the chemical, right? These are case notes that I have seen over the years. You know, they were positive on their UAs, urinalysis for 3 consecutive times, discharged from treatment for lack of compliance and treatment. I think that treatment just might need to be more accommodating to this individual, or maybe that the you know, clinician has not fully understood the kind of current motivations for use. They stayed clean for the duration of treatment. Success, right? PT was engaged in groups and maintained a positive demeanor throughout the course of treatment. PT maintained medication compliance with Suboxone treatment and its 12 negative UAs on file. I bring these up because what's missing? What's missing is any kind of element of focusing on what are important to the client, right? Client wanted an improvement in, you know, the relationship with their partner. Was that goal achieved? Client was wanting, you know, a little bit more clarity on how to proceed with their business, given a kind of a tough last year. Where are they with that goal? When we talk about substance use treatment, a lot of times we focus on support goals being, did they maintain abstinence or not? I mentioned earlier, we were going to talk about this was from SAMHSA an ASAM on the criteria. If you want to read it, you can go on the reference. This is from chapter 3 of I think this is particularly around IOP and inpatient goals. Look at these goals of early recovery stage. Number 1, maintain abstinence. 2, demonstrate ability to sustain behavioral changes, which means to sustain abstinence. Eliminate drug using lifestyle and replace it with treatment related routines and drug free activities. How many families do I work with and couples do I work with where one of them still drinking alcohol? Identify relapse triggers and develop. That's all right. That's a good one, right? Identify personal problems and begin to resolve them. Begin activity in a 12-step or mutual help program. Everything that we're doing is we're focusing on abstinence. Support goals are focused on the chemical and not the person. When we think about kind of treatment goals, harm reduction approach would flip it and say, what does your client genuinely want for their life and what's important to them and how can you help? So I want to share, for a while, I was doing a harm reduction IOP group. And the nice thing about it is that there was no charade of like people having to hide. Some of the IOP groups that I run on abstinence, you would certainly have a majority that were really kind of engaged and committed to abstinence, but you'd also have a few that felt like they had to kind of just show up and wear a mask. And so the nice thing about the harm reduction group is that they got to really talk about how they were going to make use safer and be very honest. What was important to them was somehow trying to integrate substance use into their existing life. It was a pretty wild group. I learned a lot about that group from kind of observing and facilitating, but really asking this question, what does your client genuinely want for their life and what's important to them? And how can you, as the person providing support, help them? And that's what we're focusing on. So I'm going to come back to this if we have time later. So I have another vignette. This one, I'm going to prepare you to think about the chat. It's another individual I worked with, 29-year-old Black male in a high pressure job as a lawyer, has 2 children, currently married. Cis hetero partner is quite frustrated with his substance use. Stated substance related goal is to remain clean for 30 days. Client starts the session by saying he is really tired of how things are currently going. He feels like he cannot do anything right at home and that he is at day 23 of 30 and no one is acknowledging him for his efforts. He mentions to you several times he is considering just using again because what's the point of even staying clean? So I wanted to ask, and I'm just curious if anybody would like to take a stab at what is a question or a statement you would like to share with this client, given your role? You might be a first responder, a peer support individual, a therapist, a clinician, a medical provider, but just kind of thinking back to this vignette, what would you say? There's no wrong answers. I know this one's always a tough one. Who would you most like to hear from? I like that question. Right. The individual is looking for acknowledgement of his hard work, right? Nicole with a great validation. What motivated you to seek to be clean in the first place, right? Getting to kind of motivations initially is a really, really great question, because now we're focusing what? On the person and not the substance. And Christine, what would you like that person to say, right? What are you looking for in kind of that acknowledgement? And why would that be so meaningful to you? Really wonderful. Thank you all for kind of adding. I know that can always be, feel like we're getting put in the hot seat there. So there's a few kind of ways that we can show up is as clinicians, as peer support, but I want to spend a little bit of time talking about community harm reductions strategies. And, you know, again, there's a tremendous amount of resources that can talk you through how to implement these The other thing that I want to say, because there are some ones on here that are probably a step too far for a lot of places, but think about a lot of these options, you can always start small. So syringe exchange programs, for those that are not familiar, a lot of times we see high rates of viral infections coming from the use of needles that have already been used, either shared or used consecutively by the same person, right? They're not using a sterile syringe. Syringe exchange programs are, there's a lot of different versions of them. I've seen all the way from somebody offering just kind of like like setting up a booth or something in an area, kind of a high trafficked area, and just offering. There's also some like really grassroots organizations that will just, people that will be walking out to kind of homeless areas as well as kind of known dealing areas and just offering needles that way. Probably the more common forms are usually there will be kind of a recovery organization or a harm reduction organization that will actually have a like a mobile van. This is probably the most common one that I've seen, and they'll park out in kind of a prominent known area where individuals will use substances and offer needles there. A nice thing usually with the van is that they'll also bring a nurse or somebody to kind of talk about additional options, right? Hey, these are some treatment options in our area. Hey, are you struggling with maybe a sore or something? We can take a look at it and maybe make recommendations for you at the time. So an idea is like kind of capturing somebody while they're coming to get a sterile needle, and then being able to talk to them for a minute. Hey, what's going on with you? What's your story? Where are you at? So syringe exchange programs are a really wonderful kind of form of harm reduction, because you're both reducing the harm on kind of our physical biological side, as well as reducing the harm by providing them with the ability to start to get plugged into a network a little bit, whether that is, I now know how to get treatment if I need it, right? I have somebody to talk to should I feel like I need to talk to somebody. Medical support, one that we have seen kind of a lot of is providing, kind of almost a warm handoff to somebody that might be kind of substance use, a substance use ally in the medical profession. There are a host of medical concerns and issues that come up for individuals who are using substances. So medical support is really there. What are our warm handoffs? What are the relationships that we've kind of built in our community to provide medical support for somebody using substances? Viral disease vaccines and treatment. What we know, Hep C, curable, and at the same time, very common in individuals who are using intravenous drugs. This is an excellent opportunity to start to weave in harm reduction strategies, whether they're coming as a result of hepatitis or if they are, getting clean needles, is to start talking about infectious diseases and viral and viruses and how to better show up to them and how to get treatment for them as well. HIV treatment can also be usually a very kind of common. And one thing, instead of maybe offering treatment, maybe you have the ability to offer education. So that education might be, here are one or two places that we've located, and maybe we've even talked to, that offer information on HIV treatment or hepatitis vaccines and treatment. Integrated mental health care can often be kind of a community intervention. A lot of times, again, I will see kind of a syringe exchange program or a Narcan distribution with somebody who's kind of primary mental health. Again, that might be, they'll have, kind of a van driving around the city and setting up almost like a food truck, but we're offering sterile syringes and Narcan, or we're offering Narcan and we're here to do 15-minute recovery coaching sessions. I've seen a lot of different versions, but offering kind of some type of integrated mental health care. In DC, there's a place called Community Change, where they will have a psychiatrist and a therapist once a week go out into some of the homeless shelters and homeless encampments and talk to people there and just kind of offer kind of brief consults in that moment. So being able to kind of start to create, some type of integrated mental health care, you might not be able to do a full suite of services, but just putting eyes on somebody and letting them know how to get the next step and providing next steps can be really, really meaningful. Supervised consumption sites is probably, when I think of harm reduction and what people are really struggling with, we think of supervised consumption sites, but supervised consumption sites are a place where somebody can come and bring their substances, have them tested. So you would have test kits. Test kits there's things called like little fentanyl strips. They almost come in little packets like this. You would open it up and it's almost like a dipstick. If you ever done the dipstick drug test, you would take a little bit of the substance that they can use. They would put it in the top of a bottle cap, put a little water, you dip the dipstick in there, and it would tell you the presence of fentanyl. Another way to do substance testing is also to get the substance that you want to be present. So let's say I'm, assuming that this drug is ecstasy, they'll have ecstasy test kits where you can confirm the presence of MDMA in that substance. So supervised consumption sites sometimes will offer testing of substances, as well as even kind of the most progressive ones will offer an individual, a nurse usually on staff, who will actually inject the substance in for you and then monitor for the next 15, 20 minutes to make sure that you're okay, that you're still going to kind of live through this high. Another kind of common practice that we talk about in harm reduction is building up. And so supervised consumption sites will also talk about and really enforce starting small, right? So let's say that I got 2 point bags and my plan is to use all of it. Well, supervised consumption sites would walk you through, like, do a tester. So maybe you're going to do 1/10 of that point and then see how it feels, especially with all the fentanyl around. They would say really start small. And then if you feel like it's a safe dose, maybe you do half of that next amount, but you can always build up, right? So really starting small. So supervised consumption sites offer testing, offer some insights in how to be safer while using, and then might even actually inject or provide you with the ability to use on site as well. Medication alternative programs. Let's say that I it was prescribed, Lortab after a surgery. There's a lot of wonderful organizations out there. And Ashley, thank you. Test strips are considered drug paraphernalia in Alabama, but agencies are working to get test strips decriminalized due to the fentanyl crisis, right? And we'll talk about barriers in a second. So thank you for that, Ashley. Medication alternatives, though, are really wonderful ways to talk about how to make your medication management a little safer. And that even could be, I have a Lortab prescription after surgery, but I want to be a little safer as I'm going through it, especially around dependence. I don't want to form dependence. Maybe I have substance use in my biological family and I have some concerns. This is a wonderful way to do some education around how to kind of mix and match medications to promote kind of healthier healing for people. So what are the alternatives that you have than just taking the prescription that you got from your doctor? Or what are some strategies to kind of mix in to maybe stretch out the need that you have for these medications? And then also kind of lastly, a form of harm reduction is just offering referral programs to treatment programs and providers, right? What are the local treatment programs in your area, and who are the different providers in your area, and what do they specialize in? That is a great form of making use safer. So there's a lot of different community interventions here, and there's a lot of different ways to kind of engage. The 3 resources that I'll add at the end We'll have a lot more information if you're really interested. They all have like toolkits and rollout programs where if you're interested, be like, what would it actually take to get a syringe exchange program near us? They will even walk through like how to, start talking to law enforcement and start talking to public health offices and some of the findings and research that you need to share, all the way down to kind of the implementation for your community. We'll keep going here. So we'll kind of close with some barriers. Individual barriers that I've seen as I've kind of worked with people over the years is comfort level in education. You can really learn a lot in harm reduction. And today I wanted to kind of give the 1,000-foot view, but really getting into harm reduction, learning how to like smoke powders correctly instead of ejecting, how to inject safely, how to smoke a pipe without burning yourself, how to obtain testing kits and use them, getting in the community. That is a huge barrier for a lot of people, of just putting yourself and finding the community that you want to be a part of and to show up to. And getting comfortable with slang, right? What is the kind of current, and even just over the years, I find sometimes I'm always still having to play catch up to the current slang. And then lastly, your own preconceived notions about how to support someone. That's why I kind of remind ourselves like evidence-based, right? Am I really looking at kind of the current best practices and research to support somebody? Or am I using kind of what I found worked for me or a loved one, and that's really going to be the thing that I promote. And then community barriers. When I have talked to individuals that are rolling out community programs, it seems that the biggest barrier that comes up is the community is not on the same page. And kind of primarily working with law enforcement is critical to a successful harm reduction community intervention. You almost kind of have to be hand in hand. They have to be aware of what you're doing and okay with it. Especially if you're going to look at things like doing syringe exchange programs and safe consumption sites, and almost every single one of them have full blessings from kind of the powers that be, either at a kind of county level, local level, state level. Usually you have to get a lot of these individuals involved to do it kind of on a big scale. A lot of the grassroots ones, we look back at kind of the early HIV advocates, there was no going through all those hoops. They would get out there and put sterile syringes in their backpacks and just walk around the LGBTQ neighborhoods. Also creating a diverse team of race, ethnicity, gender, sex, background. We see this really important to getting and kind of really penetrating into the community. Medical professionals, marketing, people in recovery, families, substance use disorder allies, local businesses, and people who just care. You kind of need a mix of individuals that all have to kind of show up and participate. And if you don't have that, you're going to be missing some areas that you can kind of have a better market penetration in your area. Obtaining testing kits, Narcan, and facilitating trainings can be costly and expensive. As Ashley said earlier, legality is dependent on state laws. And so Ashley, mentioned earlier, just getting test strips is considered drug paraphernalia in Alabama. I even remember like here in DC, you can walk to CVS and ask for Narcan, no questions asked. I know for a lot of states that is, there's many, many more barriers. I remember, I'm sure still some states, but, even Narcan, required a prescription. And if we go back to Suboxone and Methadone in the United States, you have these crazy parameters that you have to engage in, and they're actually creating more barriers for a lot of people, like having to drive to facilities every morning, where I can't remember, I was just listening to a researcher talk about this, but in several pockets in the EU, I can't remember which specific countries, you don't even need a prescription to engage in MAT, like Suboxone. I think Suboxone, you don't need a prescription. Methadone, you do. But it's just very different ways, right, of thinking about what barriers are we creating. So a lot of what we can and cannot do is based on legality. And I'm personally always a fan of starting small, right? Whenever there's the question of like, okay, so we learned a lot about harm reduction. There's a lot of different things we can do, and we're not going to do a lot of it. Where do we start? And I always say, what's the smallest thing that you can start with? Just like we encourage people to find motivation for their clients, and then that leads to a ripple effect. The same thing with harm reduction. What is the smallest thing that we feel like we can do in our community? And then see, can we build upon it? What was the reception of that, right? Is that handing out Narcan? Is that creating better treatment referrals to multiple pathways? Is that, talking with a local group that's, neighboring states about syringe exchange programs and how they implemented, and just getting maybe a framework of what that would look like in our area. Is that just learning, right? Is that just maybe hosting a webinar for a group of individuals in your area? So really starting small, and then building upon that is a great starting point. I think we're just about done here. Okay, resources. So if you're like, hey, this harm reduction stuff's really cool, and that guy talked a ton and I didn't retain a ton of it, but I thought it was interesting, don't take my word. There are 3 amazing websites that I wanted to share. Filter Mag is more of kind of a blog. I love Filter Mag, and it is really kind of a use in harm reduction. If you want to learn, how you can, better smoke powders, Filter Mag will have an article that you can share with a client on how to do that if you don't know. Harm Reduction Coalition is a US-based harm reduction org that has amazing research on their website. They have, when I mentioned toolkits earlier that you could use, Harm Reduction Coalition has a ton of toolkits that you can use. And Harm Reduction International is probably the best research hub out there. They post just fantastic articles. When it comes to the US, it's not always that applicable. I mean, they really honor their kind of international scope. At the same time, though, it is a great place to find what other people are doing outside of the United States. And it can kind of help with that innovative piece, right? What is maybe something that we can bring and do in our neighborhood? So those are all clickable links, and I see Ashley is adding them to the chat as well. Here are my references. I will send slides out so you can use that. And so I add this, learn, build, measure. In the product management world, we talk about this all the time is, first off, learning. What are we learning? What is the feedback that we're getting from people? Are we talking to people? Let's build something then based on this feedback, and then we measure it. Was it successful? How was it? And then that leads back to learning. So I always just like to close with that, as I think we're all in a state of learn, build, and measure as we're building anything, products, or working with people, or rolling out community interventions. So I know I talked an absolute ton, and I would be happy to answer any questions. I know Ashley's going to close us out, so maybe 5 to 7 minutes of questions before Ashley closes out with just, I think, some CE updates and whatnot. So ask questions. There's a Q&A function on Zoom, but you can also just put them in the chat. I have both pulled up. See some thank yous. That's awesome. How do we get our CEUs? I think Ashley is going to come on in just a minute if there's no other questions to answer. Gene, groovy, nice. And also I am going to add might want to explain craft to newbies. Just a super brief. Craft is community reinforcement and family training. which is a harm reduction-esque family treatment modality. We're basically kind of like child-centered, it's not child-centered play therapy, but where you're kind of teaching like the parents and how to engage as a family. Craft is a very similar, but it's kind of a set of strategies and skills to kind of show up to the use that a loved one is having in a family. So slides will be available, Tara, and actually I will put that right now in the chat, and then I will hand them to Ashley as well. So that link that I just added in the chat, you can take that and you'll have access to the full slideshow and use it, repurpose it, steal it. It's not that important. So make it helpful for you. Oh, and also that's my contact information as well. And I will put that. Please email me. I'm pretty responsive via email. You can also text that number as well if you have any other questions, or if you left here and you're like, I don't agree with any of this, like that's also a great conversation to have. So I would be happy to have that conversation. Oh, and I see L, I don't know how to Cowtree. I just want to elevate. I have to admit, I had a judgmental outlook toward those who use substances, even from a professional. This has really helped me. Thank you for saying that. I think we all, I don't know, I know that out of all the different fields and how we show up, and I think we all come into this world with a set of ideas and preconceived ideas about, you know, certain behaviors or certain attitudes or perceptions. And I just appreciate your honesty around and being open to having that outlook changed. So thank you. All right.
Okay. Jack, I actually have a quick question. Just thinking about this, but I work with the Addiction Prevention Coalition, and we're all on board with harm reduction. So it's a common conversation for us to have. Just talking about needles or whatever. How would you recommend someone, I guess, have that conversation with their coworkers or maybe their supervisor of maybe this is something we should start implementing more, and talking about harm reduction with clients?
Yeah, it's a good question. And to make sure I understand, like, how do I kind of show it to maybe where I'm working and having that conversation with the people I'm working with to make that a focus?
So you're starting to, I guess, normalize harm reduction.
Yep.
Or kind of implement it and get people thinking about it.
Yeah, actually, it's a good question. I think one of the biggest things that I've learned is just kind of throwing it out there. I've always kind of name it and see kind of where are people at initially, right? I also do think about like, so one thing that we sometimes do is we think out of scope, and then we see, well, what does in scope look like? And so out of scope would be like, what is the thing we would love to do, but it's probably going to be a stretch for our, and that might be just for our colleagues, or that might be out of scope of our mission as an organization. And then if that's out of scope, but that's something we would like to do, or as an individual, I'm kind of showing up to, then how can we make that in scope? So still honoring that we would like to move towards the out of scope thing. So that might be, I would love to have a syringe exchange program based out of our recovery community organization, right? And my coworkers like, what are you talking about? There's no way in hell we are going to do that here. But then it might be, okay, well, I hear that. But I do think that part of our mission, our work, is really to offer better information on syringe exchange programs. So maybe one thing we do, what if we got together, and so now we're kind of changing the scope into something that might be a little bit more palatable for our coworkers. But it's hard. I mean, I think it takes a lot of conversation and like easing into things rather than just saying like, we're going to move forward with this.
Yeah, that's an awesome answer. Thank you.
Yeah.
Let's see. So I'm not seeing any more questions or any questions in the Q&A or in the chat. So we can just go ahead and wrap up. I actually dropped the link to the evaluation in the chat just a few minutes ago. And I will actually put it in there again, just so it's bump back to the top. Like I mentioned earlier, your post attendee page from Zoom should pop up and take you directly to the evaluation. You only need to do that one time. And then if you need a certificate, just please fill out the CE request form. And then if you have any questions, I'm putting my email in the chat as well. And you can just reach out to me there. But thank you so much, Jack. You're so awesome. This is such a great topic. Well, it's a hard topic to have to talk about and introduce to people, but you did an excellent job. So
Awesome. Thank you, Ashley. And thank you, everyone. Hope you have a good rest of the day.